Hi, this is Brad, and this is a presentation on scaphoid fractures. So usually the patients that we'll see um, will be people who are just coming to us complaining of pain in their hand, and they don't know what's wrong. Or these people will have a diagnosis of a scaphoid fracture and coming to us. So those are kind of the two camps of people that we would see for this. So just some statistics on scaphoid fractures. They account for 60% of all carpal fractures, 11% of hand fractures, 2% of all fractures. Um, and the mechanism of injury is usually a fall on an outstretched hand. And then there's some different percentages on where they occur in the scaphoid bone, which we'll get to a little bit later. So a refresher on some anatomy, just so everyone knows like where in the body we're talking about. The scaphoid bone, which is one of the carpal bones, and the tubercle, which is like a prominence on the just distal to the flexor crease. And then another important anatomical landmark to know is the anatomical snuff box. So separate or the bordered by the abductor pollicis, extensor pollicis. Um, and so the anatomy is just good to know because some of the clinical signs will relate to these anatomical landmarks. So these are clinical signs and demographic predictors for a scaphoid fracture. Tenderness in the anatomical snuff box, pain with pinching the index finger to the thumb, tenderness on the scaphoid tubercle, axial compression of the thumb, decreased range of motion, and anatomical snuff box pain with ulnar or radial deviation. And then some demographic predictors are male gender, sports, and these patients are usually on the younger side. Okay, and then some CP clinical prediction rules that we went over. This is from a study done by Duckworth et al. Um, so as stated before, usually this will occur more often in males, usually due to some kind of sports injury, anatomical snuff box pain with ulnar deviation at 3 days, and then tenderness over the tubercle at 2 weeks. And the 2 weeks is important because maybe the injury will happen. They'll go get imaging done and it won't show anything. But that might be because of the edema. So if the imaging comes back negative, but they're still complaining of pain, then if there's still tenderness at the scaphoid tubercle at 2 weeks, might be still indicative of a fracture. So you might want to refer them to go back for some more imaging to get this looked at. And then when all four of these are present, there's a 91% chance of a fracture. Here's another kind of like clinical prediction rule by a different study. Again, anatomical snuff box tenderness, tenderness over the scaphoid tubercle, and pain with axial loading of the thumb. And there's some sensitivity and specificity data for this too. Okay, so some other conditions that we might be looking at if someone were to come and complain about hand pain, other types of fractures, scapholunate ligament rupture, and then arthritis. And arthritis is kind of the big one where it might be more necessary to use those clinical prediction rules to try and detect a fracture. Because if any of those other fractures, we'd still be sending them to imaging regardless. So it wouldn't be very useful to differentiate between the types of fractures because the end result would be the same. But definitely using those clinical prediction rules if we don't know quite what's wrong yet and we're thinking it might be arthritis or it might be a fracture. So then if we use those CPRs and just suspect a fracture and it's not arthritis, then send them for imaging. But if it's more arthritis, then we can just kind of handle that on our own. Okay. And then there's a few few slides coming up that are just treatment classifications based on the location of the fracture, whether or not the fracture is displaced, how much it's displaced, and some other complicating factors. So the three general locations of a scaphoid fracture could be the waist, which is the middle, the proximal pole, and the distal pole. So here's the algorithm for a fracture that might occur at the waist. So if it's not displaced, generally looking at more of a shorter term cast, 6 to 10 weeks. 10 weeks if it's complicated by other factors such as comminuted fracture, reduced compliance, and smoking. And then even shorter than that if there aren't that many complicating factors. If the fracture is displaced, the amount of displacement is up there on the slide, but generally looking at maybe a longer term cast or operative treatment if the displacement is greater than 1.5 millimeters, or if they have those complicating factors that are listed on there. Okay, and then here is the algorithm for a fracture that would occur at the proximal pole. So non-displaced fractures that are less than 0.5 millimeters could be short-term cast or operative treatment. And then if it is displaced, operative treatment and not so much considering the casting. And the prognosis for each of these and like why the proximal pole is maybe more, you might consider operative treatments rather than like a 6-week cast. I'll get to that a little bit later with kind of relates to the blood supply to these different areas. Okay. And then the other location that a scaphoid fracture could occur is the distal pole. So you could have a wrist cast for 4 weeks, short-term casting for 4 weeks. And then again, depending on how much it's displaced, less than 1.5 millimeters, casting for maybe 4 to 6 weeks, or if it's displaced more than that, considering operative treatment. Okay, and then here's the blood supply to the scaphoid bone. 70 to 80% is supplied by the dorsal branch of the radial artery. 20 to 30% is supplied by the superficial palmar arch. And the waist and the distal pole, so the middle part of the bone and the distal part of the bone are better vascularized than the proximal pole, which is why the prognosis is generally better. You could probably get away with like a short-term cast more so than operative treatment. The proximal pole is less vascularized, so you might be able to do some short-term casting, could be considered, but you're probably more likely that it'll end up being operative treatment. And the time to recovery will also take longer with a proximal pole injury. Okay, so physical therapy for a scaphoid fracture. In the early stages, you'll have some swelling. Again, that swelling could throw off imaging, but to help decrease that swelling and educate the patient to keep their hand elevated as much as possible. And also in these early stages, when it might still be painful to move it around, consider interventions that focus more on more proximal joints, such as the elbow and shoulder. So could be using some interventions that we learned earlier in this class to make sure those joints are moving well. And then after immobilization, they'll be stiff. So the focus would be on regaining range of motion and strength after that. So we could use some passive mobility techniques such as those wrist glides that we learned for CMC distraction that we practice in class 2. And then these are just some ideas for, again, after immobilization to get that strength and range of motion back. So scrunching a towel or like a napkin or something, some wrist strengthening, or could also be just to facilitate that motion that was gained with any like passive manual therapy type techniques. Into flexion extension, you could also do pronation, supination, and in different planes too, different anti-gravity positions or gravity lessened positions. And then using a squishy ball or like putty, squeeze that in between your fingers. Use different fingers to squeeze it, and then the I'm not sure what it's called, the finger web and that's the picture in the bottom right, again to strengthen those finger flexors. You can also go into extension using that web. Okay, so there are my references, and thanks for watching.